Very good morning, sir. Respected Emeritus Chairperson, sir. Pro Vice Chancellor V.K. Kapoor, sir. Medical Director S.S. Jaiswal, sir. And Hemant, sir. And other senior faculty, colleagues, and my dear students. Today, I am going to present CCR from the Department of Immunohaematology and Blood Transfusion. This is our mission and vision of our department, where we are working on to provide best-in-class, safe, secure, and cost-effective, hassle-free supply of blood products and perform critical services. And our mission is to make a center of excellence of blood transfusion services by providing safest possible and clinical application that ensures the highest quality product and services. This is our journey of our blood center. We got license in 2001 for whole blood. Then in 2012 we got the license for the components. Then we were the first who start transplant immunology lab in the state of Rajasthan to cater the need of transplant program in our state. Then in 2016 we started ABO in compatible renal transplant. And then 2017 this was the first NABH accredited blood center apart from hospital in the state of Rajasthan. In 2020 we got the license for peripheral blood stem cells, granulocyte. Then 2021 we got the 2 seats from NMC for the postgraduate MD program. In 2021 we were the first who received the quality certificate from American Association of Blood Banks. Till then we are maintaining these credentials, and this year we also apply for accreditation program. Initially we got the certificate, now this year we applied for the AV accreditation program. And we also perform harvesting of lymphocyte for CAR T cells, and recently this year only we got the license renewal, and at present we are the license holder of maximum products we can manufacture in blood bank. And we started DNA fingerprinting to cater the need of kinship analysis for transplant program. And recently we got approval from university to make a center of excellence for hemoglobinopathies and hematological disease and research. Dr. Rachna Narayan is presently our professor and head. Just because of some health issue he is not joined today. And PG resident, presently we are having 2 seats per year, and currently we are holding 6 residents along with 3 students who are pursuing PhD in immunohematology and blood transfusion. We offer 2 seats in MD IHBT and PhD programs. Presently services available are, we are amongst India's distinguished center which are accredited and providing comprehensive, integrated, advanced transfusion and high complexity testing services, which includes manufacturing of blood and component, processing and distribution, then diagnostic test for immunohematology, transplant immunology, flow cytometry, molecular testing and DNA fingerprinting. Apart from that, we are also involving in various therapeutic procedures and certain distinctive services which are unique to our department. Distinct services are the therapeutic plasma exchange and double cascade plasmapheresis, and recently we done one immunoabsorption in ABO compatible for liver transplant program. And intrauterine transfusion we started since 2015. Then presently phenotype matched, leukodepleted and NAT tested blood products we are providing. This is again one of the USP of our blood center in the state, where we are giving complete phenotype and NAT tested blood to all multi-transfused patients. And thalassemia screening by HB electrophoresis by the grant of Honorable Emeritus Chairperson, sir, we started free screening for all the antenatal cases are coming to us. We are charging 1 rupees cost for screening of the HB electrophoresis. This is the achievements of the department. We already explained. We are the first. This was the first. Yes, sir. We done, sir.
Mentioned as a distinction in your department, T cell collection.
Yes, sir.
Prior CAR T cell.
Yes, sir. We have mentioned, sir. lymphocyte, not only for CAR T cells, sir, we are also collecting monocyte for production of dendritic cell vaccine, which program is going under the leadership of Dr. Suri sir. No, sir. Leadership. And this is the assessment ranking by Ministry of Health and Family Welfare, where we stand first ranking in the state of Rajasthan. And this ranking is done along with the US agency CDC, that is the US Center for Disease Control and Prevention. And the achievements of the department, this year we received this international collaboration, and we got European Commission grant. And in this, we really wanted to extend my thanks to Dr. V.K. Kapoor sir. Under the leadership of him, we are able to participate in this program, where the 12 international universities are participating. And the project is to again strengthen the transfusion services across the globe. We also recognize various novel allele, which was recognized by the WHO nomenclature committee, and grants for that project which we received from Erasmus. The project name is the Transmed Africa, and we also received intramural grant from our university for thalassemia mutation detection by next generation sequencing and KIR genotype, which is going to be very useful for hematopoietic stem cell transplant program. And we also received national and international travel grants. These are the two MBBS students who participated and went for present their paper, and one of our students also received very prestigious T.X. Miller Award. This is the paper presented by our resident in various conferences. We attended more than 50 conferences, and organized by department more than 20 conferences and workshops we organized. Research project we completed, 5 research projects already completed and published in reputed journals, and presently 8 projects are still going on. This is a publication profile where we are guiding more than 50 research projects. Article published in various journals is the 54, paper presented in the conference apart from oral presentation and poster presentation, and we also involved in the society working document, and chapter published was 4, and with more than 100 citations, 1000 citations at present. This is a various publication which published in the very reputed Vox Sanguinis and Transfusion journal. Then research innovation, and presently we are providing various tests at our blood center. So near about we can see since last 4 years we are 3 times performing more tests for blood grouping and cross matching. In 2022 we are doing just 23,000, and right now last year we reached up to the 52,000, and just to the data of July we crossed 34,000. This is the donation and issue statistics, which again highlights the increased workload of our department, because various transplant program and various super specialties are working to cater the need of everyone, our blood center giving support. This is a special procedure where we are doing therapeutic plasma exchange, granulocyte and peripheral blood stem cells, and DFFP, that is the double cascade filtration procedure. This is a various specialized test for HLA, flow cytometry, electrophoresis and molecular test. We are very proud to say that presently we are catering the need of our state for HLA testing for disease donor program. Initially these tests was sent to the Delhi at the midnight, and just because of this provision various genuine recipient missed, because when the last flight from Jaipur to Delhi went, so that's why right now we are getting all the tests even at the midnight. Within a span turnaround time of 5 to 6 hours we are able to give all the testing results. This is the certificate of American Association of Blood Bank and NABH, and this is a various outreach activities and various media publication by our activity of our department. Recently we start we are working on the project online project paper-free project to aligning the department objective with organization goals. We are doing everything in online from request to issue of the blood product. So now you can track all the request, issue and readiness of blood from your own system in your department. Our main strength are the dedicated, competent and trained supportive staff, and I am really thanks to sir, because whenever we required any equipment, sir always say yes, and the state of art equipment availability, advanced immunohematology lab, NAT lab, transplant immunology lab, flow lab and sequencing lab. Presently we are having next generation sequencing as well as Sanger sequencer and SafeTrans software. Our future plan is going for the cell and gene therapy. We also offer to start international proficiency testing program as a nodal center in Asia Pacific country and develop an international and national training and reference center and bone marrow registry. With this, just I would like to invite Dr. Nisha to take forward.
Respected Emeritus Chairperson sir, Pro VC sir, Dr. Hemant sir, and all senior faculty members, colleagues and friends that are present here. I, Dr. Nisha Raj, third year resident of the Department of IHBT, welcome you all to today's CCR presentation, a postpartum storm where transfusion medicine made the difference. This CCR is being presented by the Department of IHBT in collaboration with the Department of General Medicine, Department of Gynae and Obst, and Department of Clinical Haematology. I would now like to invite Dr. Bharat on stage to take the case forward.
Good morning, respected Emeritus Chairperson sir, professors and everyone present here. Today we are going to discuss a case of 26-year-old female, uneducated, farmer by profession, lower social economic class, resident of rural areas near Alwar, presented on post-operative day 1 following a full-term emergency lower segment cesarean section done at other hospital in view of abruptio placentae with intrauterine fetal demise. Patient was referred to an institute in view of decreased urine output for 1 day and delayed laboratory investigations. Patient went into labor and emergency LSCS was done at local hospital in view of abruptio placentae with intrauterine fetal demise. During the post-operative period, the patient's clinical condition deteriorated over the first 24 hours. Patient was referred to an institute for further management. Post-operatively, she developed markedly reduced urine output. In 24 hours, she had passed 350 ml of urine. The oliguria was persistent for the first 24 hours post-operatively. Patient's outside investigation suggestive of raised TLC, low hemoglobin, low platelet count, high total bilirubin, raised SGOT and PT, and raised serum creatinine. Patient had no complaints of shortness of breath or cough, loose stool or vomiting, and no excessive pervaginal bleeding was found. Patient had no prior history of blood pressure, diabetes mellitus, thyroid disorder. As per patient attendant, and her ANC period was uneventful and she has not done routine antenatal checkup. Patient was vegetarian by diet, non-smoker, non-alcoholic, and there was no history of drug addiction. So to summarize, a 26-year-old female presented on post-operative day 1 following an emergency lower segment cesarean section in view of abruptio placentae with intrauterine fetal demise with complaint of decreased urine output and deranged laboratory investigation. Our clinical possibilities were DIC secondary to abruptio placentae, hemolytic uremic syndrome, HELP syndrome that include hemolysis, elevated liver enzyme, low platelet count, thrombotic thrombocytopenic purpura, sepsis with MOTS. The patient was shifted to ICU for further management. Patient was conscious and oriented to time, place and person. Weight was 70 kg, height was 153 cm. Pallor was present. There was no evidence of icterus, cyanosis, clubbing, lymphadenopathy and edema at this point. Patient blood pressure was 110/70 in supine position. Pulse was 92 beats per minute, regular, normal volume, normal character. All peripheral pulses were palpable. Patient was afebrile and maintaining a saturation of 97% on room air. All systems were within normal limit at this stage. Respiratory, cardiovascular, abdominal and neurological examination did not reveal any local findings.
Any signs of bleeding, mucosal or
No,
No
sir.
skin, no bleeding.
No, sir.
No petiki, no echocardiography.
nothing, sir. On admission, investigation was sent, which showed TLC was 32,500, hemoglobin was 9.7, platelet was 31,000, creatinine was 3.28, blood urea was 73.8, total bilirubin was 3, direct was 2.2, and indirect was 0.8. SGOT was 10 times the normal limit, SGPT was 6 times the normal limit. Total protein were low, LDH was 2000, PTNR and APTT were mildly prolonged. Bedside USG was done, which showed bilateral mild hydronephrosis, mild ascites, bilateral kidney were mildly echogenic with partial loss of corticomedullary differentiation, and uterus was bulky, showing postpartum status. So to summarize, a 26-year-old female presented to us on day 1 of emergency LSCS in view of abruptio placentae with intrauterine fetal demise with decreased urine output and deranged laboratory investigation. Clinical examination were within normal limit and no focal finding were found. Laboratory investigation showed anemia, hemolysis, thrombocytopenia, deranged liver function test and renal function test, and prolonged PT-INR. On the basis of this, differential diagnoses were made, which include hemolytic uremic syndrome, HELP syndrome, thrombotic thrombocytopenic purpura, DIC secondary to abruptio placentae. The case was discussed and the report was awaited at that moment. Based on this, discussion was done and Department of Nephrology, Obstetric and Gynecology, Clinical Haematology, IHBT reference was given. Nephrology opinion was taken and advice of renal monitoring was given. At this point, there was no active intervention from team of nephrology.
Patient was admitted in MICU under the Department of General Medicine and a reference call was given to our department. Patient X, 26-year-old female, para 1 with no live issue, post-operative day 2 of lower segment cesarean section, operated at other hospital in view of abruptio placentae with intrauterine fetal demise. As per patient and attendant, she was not on any regular antenatal checkup and her antenatal period was uneventful. On general examination, patient was conscious, oriented to time, place and person. BP was 118 by 80 mmHg. Mild pallor was noted with no signs of icteria, cyanosis, clubbing, lymphadenopathy and pedal edema. Bilateral breasts were normal. On per abdominal examination, abdomen was soft, bowel sounds were present, uterus was well contracted, approximately 20 week size, phalansteal incision with sutures in situ. Stitch line was healthy with no discharge or induration seen. Dressing was done. On per speculum examination, no excessive vaginal bleeding was seen. Lochia was healthy, not foul smelling. Foley's catheter in situ with urine output approximately 10 to 15 ml per hour. On advice, we advise monitor vitals and BP monitoring to watch for uterine tone and vaginal bleeding, stitch line care, hourly input-output monitoring. As patient was already tolerating liquid diet, we allowed semi-solid diet, early mobilization and tablet cabergoline 1 gram per orally. As already all the required investigations were already sent by the Department of General Medicine, we advised 24-hour urine protein. Along with that, we had a daily follow-up for the general condition and the stitch line care of the patient.
Thank you, Dr. Kritika. Good morning to all. I am Dr. Vijeta Niranjan, Senior Resident, Department of Clinical Haematology. The hematology reference was sought for a primary gravida on day 2 of LSCS for abruptio placentae and IOD with anemia, thrombocytopenia and suspected thrombotic microangiopathy. The complete blood count on day 2 of LSCS showed low hemoglobin of 8 gram per deciliter with high TLC of 28,600 with the neutrophilic predominance, low platelet count of 27,000 with the low MCV of 72.8 and low MCH of 23.1. The peripheral blood film showed RBC predominantly of microcytic hypochromic with the anisopoikilocytosis in the form of cystocytes, spherocytes and the fragmented cells. WBC showed high TLC with neutrophilic predominance. Platelet count were reduced on the number and there was no any hemoparasites or abnormal cell found on peripheral blood film. So by looking the peripheral blood film, we further advised the other investigations that showed high LDH of 2061, high immature platelet fraction of 18.4%, high retic count of 12% with the corrected retic count of 8.7%, while normal serum fibrinogen and D-dimer levels, and the normal Coombs direct and indirect test. So the clinical presentation in this case was the hemolysis, the presence of hemolysis as evident on the peripheral blood film in the form of cystocytes, fragmented cells, high LDH, high retic count, along with low platelet counts with the elevated liver enzymes and deranged creatinine. So on the basis of the clinical presentation and the lab parameters, we made a differential diagnosis as the disseminated intravascular coagulation versus pregnancy-associated thrombotic microangiopathy that include the causes like thrombotic thrombocytopenic purpura, HELP syndrome, atypical hemolytic uremic syndrome, and antiphospholipid syndrome.
So how do you explain the leukocytosis?
Sir, leukocytosis...
Because of infection, or is it because of a hematological reason?
Sir, there may be some form of sepsis as she is postpartum LSCS with the abruptio placentae, so there may be some systemic inflammatory response that may lead to...
So I would feel that it's the body's reaction to the hemolysis.
Yes.
And the marrow is,
marrow is producing
overdrive.
Yes, sir.
It's producing more WBCs.
Otherwise
That could be one
also-
explanation.
Otherwise also, leukocytes are more during pregnancy. She just delivered. So that is also the reason. That could be the reason apart from these tests. All right?
Yes.
TLC normal pregnancy में comparatively ज़्यादा side
Yes.
higher side में.
To evaluate the DIC, we scored the International Society on Thrombosis and Hemostasis score, that ISTH, that includes the INR, PT, fibrinogen, D-dimer, and the platelet. So in our case, the ISTH score was 3. That means the non-overt or the absence of DIC in our case. A next differential diagnosis was pregnancy-associated thrombotic microangiopathy. So these three syndromes, the HELP, thrombotic thrombocytopenic purpura, and atypical HUS comes under. So how to identify among all three? It is based on the timing. The HELP syndrome is usually seen in the last trimester or in the first week of postpartum. TTP can present at any time point, while the atypical HUS usually present during postpartum state. The platelet count will be more reduced in case of TTP. LDH will be more high in case of atypical HUS. The liver enzymes will be more elevated in case of HELP syndrome, while the renal failure will be more severe in case of atypical HUS, and the neurological symptoms will be more prominent in case of TTP. While the Adams-13 level will be low in case of TTP, and the complement abnormality will be seen in atypical HUS. So based on the presentations and the lab parameters of deranged renal failure, deranged creatinine, and the increased liver enzyme, we conclude the most likely diagnosis in our case was atypical HUS versus HELP syndrome. Since the clinical presentations and the lab parameters are similar in all the cases, so to evaluate the further cause, we have advised the other investigations that include Adams-13 activity in antibodies, complement factor H antibody, lupus anticoagulant, and CSF emitter. Sir, Adams-13 is basically the large multimoles of von Willebrand factor. These are the antibody. These are the Adams-13 cleaves the large multiples of von Willebrand factor. So, in case of Adams-13 deficiency, these von Willebrand factors are not able to cleave, so they get adhered to the endothelium and causes the more adhesions of the platelet that leads to thrombotic injury, hemolysis, and microvascular. No, sir, there is no role of vitamin K in this. We also calculate the plasmic score. This is the predictive score used in suspected TTP. This score estimates the possibility of Adams-13 deficiency. In our case, the plasmic score was 6, that is high. That indicates the high risk of severe Adams-13 deficiency. This score is particularly relevant while deciding whether to start therapeutic plasma exchange. High plasmic score indicates to start therapeutic plasma exchange while awaiting for Adams-13 report. So on the basis of the clinical presentations, the range lab parameters and the scores, we have recommended to initiate the therapeutic plasma exchange with the daily hematological parameter assessment in terms of LDH, PVF, retic counts and the platelet counts. Avoid platelet transfusion unless any bleeding, and reference to the Department of IHBT was sent to consider for therapeutic plasma exchange. Thank you. Now I would like to invite Dr. Nisha Raj, Department of IHBT.
TTP, you should have some thrombosis or cutaneous manifestations.
Yes, sir. Sir, in this case, there is no evidence. Only on the basis of consumption, like low platelet count and the evidence of hemolysis, we assume it is a microvascular thrombosis. But as such, there is no radiological evidence of thrombosis in this case. Also, sir, INI was 1.4. So I would like to invite Dr. Nisha Raj to take this case forward. Thank you.
Thank you, Dr. Kritika. Good morning, everyone, once again. So, just to recapitulate, she is a 26-year-old female. She is a primigravida, operated for lower segment cesarean section for an IUFD and abruptio placenta at an outside hospital. Was referred to our center with the complaints of low urine output, leukocytosis, thrombocytopenia, and anemia. Sir, actually just a revision slide. And leukocytosis, anemia and thrombocytopenia. She is admitted in the ICU, extensively investigated, and a primary diagnosis of pregnancy associated thrombotic microangiopathy is made, and we receive a reference in view of therapeutic plasma exchange. But before I go forward with the case, I would like to mention two terms over here. First is plasmapheresis and the next is TPU, or therapeutic plasma exchange. In our clinical practice, we usually use these terms interchangeably, but I would like to mention both these terms are completely different. So plasmapheresis is about donor apheresis, where we are only removing the plasma. For example, when we were removing plasma, COVID convalescent plasma during the COVID times. Whereas therapeutic plasma exchange, as the name suggests, is a therapeutic procedure, and it involves exchange where the plasma is being removed and is being replaced with an adequate replacement fluid. For example, we are doing therapeutic plasma exchange for multiple cases in our center, including GB syndrome, optic neuritis, transverse myelitis, ALF, ACLF, etc. We are using this procedure for different cases. So just to mention, plasmapheresis and TP are completely different. So when you send the request form to us, I would request you to please mention therapeutic plasma exchange instead of plasmapheresis. So what is therapeutic plasma exchange? So therapeutic plasma exchange is the removal and retention of the plasma with return of all the cellular components to the patient with the purpose of removal of the antibodies, metabolites and the immune complexes. Now, as you know, we had received the reference for this patient for therapeutic plasma exchange. We examined the patient, we evaluated the patient, but what is your opinion? Should we do a plasma exchange for this patient or should we not do? Any opinion from your side? No? Okay, so we evaluated this patient. We examine the patient on the basis whether this patient is going to benefit from a therapeutic plasma exchange or not, whether she is fit to undergo the procedure or not, and we came to a decision that we will be doing the plasma exchange in this patient. But why? So while the diagnostic workup is going on, the TS13 reports are awaited, TP should be started empirically while the reports are awaited. Now, whenever we do any procedure at our blood center, we are following the international guidelines. We follow the American Society of Apheresis guidelines, which has divided 91 diseases with 166 indications, categorically divided into 4 categories and 2 grades. This is the disease in concern over here. Now, how does the removal happen? We are saying that we are going to do a therapeutic plasma exchange and we are going to remove the plasma of this patient, and along with that plasma, the pathological substance is going to get removed. But how does the plasma get removed? So we should understand that we have the fluid component and the cellular components in our blood. So the fluid component is plasma, and the remaining cellular components include the RBC, the leukocytes, the platelets. Each and every constituent in the blood has a different specific gravity. So based on the specific gravity, when the blood sample is centrifused, they form layers. The lightest layer forms the topmost layer, and the heaviest layer will form the bottom layer. So plasma has the least specific gravity and it forms the topmost layer, and based on this principle the removal takes place. So this is the equipment that we have at our center. This is an ultra modern multi-purpose machine. This is the Comtech machine from Phoenicius Cabby. It can be used for multiple procedures which include CAR T cell product collection, stem cell harvest, granulocyte collection, along with therapeutic plasma exchange. And I am thankful to the management for providing this machine to us so that uninterrupted therapy can be given to patients whenever required. Sir, Comtech हमारे पास में दो है. We have two Comtech machine and one spectroptia machine. So altogether 3 machines we are having, sir. So how does the machine work, or what is the basic flow of the process? So we need a good vascular SS. So the central venous SS is taken and HD cath is placed. Either it can be in the internal jugular vein or the femoral vein, and the SD cath is connected to the machine. The blood is drawn from the patient. It is mixed with an anticoagulant. We use ACD as the anticoagulant over here. It is passed into the centrifuge. The centrifuge speed is between 2000 to 2200 RPM per minute, and based on the principle that I just discussed, the plasma gets removed and it is transferred into the waste bag. The remaining constituents of the blood are then mixed with the replacement fluid that is decided as per the patient's condition, and along with the calcium supplementation, it is again replaced to the patient. So this is the machine works on the continuous flow centrifugation process. That means that this process is a continuous process and the removal and replacement keeps on happening together. Now whenever we talk about removal of a pathogenic substance, we need to know where the pathogenic substance is placed, whether it is in the intravascular compartment, whether it is in the extravascular compartment, and what is the mobility between the intravascular compartment and the extravascular compartment. On the basis of this, we will be able to decide how many cycles the patient requires, how frequently the procedure needs to be done, and how much of volume during each procedure needs to be exchanged. Any procedure will require the prerequisites and the procedural considerations. For this patient, the blood grouping and antibody screening is required. Weight and height of the patient needs to be documented. A hemoglobin of at least 7 gram, hematocrit of 20%, platelet counts of at least 50,000, and a normal ionized calcium, serum electrolytes and serum proteins is required. A good venous SS in the form of the central venous SS is required. The reason is that if the blood flow becomes interrupted, the layers will not form properly and a proper plasma layer will not be formed, and we will be actually losing the cellular components also, which will lead to drop in the hemoglobin and the platelet count later on. Replacement fluid needs to be decided prior to the procedure, and anticoagulation is required during the procedure.
What are different replacement fluids?
Sir, sir, we have option of 5% albumin and FFP at our center. We can use only albumin, only FFP, or a mixture of both albumin and FFP. So this is a request form that we receive, and this is our procedural consent form that we sign before the procedure is done. Moving forward, plasma volume to be removed. So a plasma volume needs to be calculated before we decide for a procedure, because only then we will know how beneficial it will be for the patient. So when the plasma volume is removed, which is equal to the patient plasma volume, it is known as a one volume plasma exchange. And when a one volume plasma exchange is done, it is expected that it will reduce at least 30% of the pathogenic substance from the patient's system. But when we do subsequent plasma exchange, that is a 2 volume plasma exchange or a 3 volume plasma exchange, it does not increase the removal. Rather, we would only expect 10% of removal of the pathogenic substance. So it is advisable that only 1.2 to 1.5 plasma volume exchange be done during each cycle. So how the calculation is done? So we have two formulas, the Glitcher's rule of 5 and Nadler's formula, based on which we calculate the total blood volume. And based on the formula given in red, once we calculate the total blood volume, we can calculate the total plasma volume, or this will give us a 1 TPV. Now, as sir had also asked, we have two replacement fluid options available at our center. One is the albumin and the next is fresh frozen plasma. Comparing both these replacement fluid options, the albumin has lower risk of adverse reactions, less risk of transfusion related complications, easier to store and administer, and it is generally well tolerated. On the other hand, FFP has a higher risk of transfusion related complications, requires matching of blood types. But we should remember that fresh frozen plasma replaces all plasma proteins including coagulation factors. So for this patient we had chosen FFP as the replacement fluid.
FFP and cryoprecipitate same thing, synonymous or
Sir,
different?
from fresh frozen plasma we are preparing the cryoprecipitate, sir.
What that contains?
Sir, it contains the factor 8, sir. Mainly? Yes, sir, mainly factor 8, sir. Fibrinogen. So we use the FFP, sir, and from FFP we are precipitating the cryoprecipitate, and the remaining part that is remained is the cryopoor plasma, and we can use cryopoor plasma also as a replacement fluid. So now we have come to the conclusion that a therapeutic plasma exchange needs to be done in this patient. Then we receive the request form at our blood center, and once the request form is received at our blood center, the samples and the request form are received at the blood center. We need to undergo certain tests, which includes the blood grouping of the patient, the antibody screening of the patient, which includes DCT, ICT, and the antibody screening in the form of the 3-cell panel, including the cross-matching. Now, all these processes that I have mentioned over here are done through the automated machines. Again, thank you to sir for providing us these machines. We have two of these. These machines are totally automated, working on the column agglutination technology, well equipped, and they can do all these procedures in total automation. So likewise, the blood grouping of this patient was done. She was a BRH positive patient. The DCT was negative, the ICT was negative, and the 3-cell panel was also negative. That meant that no auto or allo antibodies were present. Now a central venous catheter was placed for this patient. In the right IJV, an HD cath was placed. The replacement fluid, as I discussed, was decided to be fresh frozen plasma, and the volume to be exchanged per cycle was decided to be 1.2 plasma volume, and the blood flow rate during the procedure was kept at 50 to 60 ml per minute, but this is variable, sir. This can be changed as per the patient's condition. In case the blood pressure is dropping, then the flow rate can also be reduced as per the patient's condition. Now, role of TP in pregnancy associated thrombotic microangiopathies. So, TP is associated with improvement in the treatment outcome of such patients, and TP should be initiated as soon as possible once the diagnosis is made within 24 to 48 hours, and it falls under the ASFA category 3. So, TP is not without risks. There are certain adverse events that may be associated with the procedure. So we should watch out for hypotension, electrolyte imbalance, citrate toxicity, vascular SS complications, and vasovagal reactions. So a total of 3 procedures had been done for this patient on alternate days. We can see here that initially this patient, when she came to us, she had low hemoglobin, her platelet counts were low, she had leukocytosis, she had thrombocytopenia, her liver enzymes were deranged, as well as her creatinine and urea were also raised. But by the time this patient was discharged, we see that there was significant improvement in the LDH. There was significant improvement in her platelet count, her hemoglobin improved, her liver enzymes improved, including her creatinine and urea. The peripheral blood smears were done during the hospital stay. Initially, we see that her peripheral blood smears showed cystocytes, spherocytes, there was polychromasia, there was thrombocytopenia. But after the 3 cycles of TP, there was the signs of hemolysis had improved. The spherocytes were absent, the polychromasia was improving, as well as the thrombocytopenia was also improving. So the protocol followed for this patient was 3 procedures of therapeutic plasma exchange done on alternate days with a 1.2 total plasma volume exchange during each cycle. The cycle durations lasted between 1 to 3 hours. The clinical outcome of the patient that we saw in this patient showed hemolysis resolved, the platelets recovered, and the liver enzymes normalized, and the creatinine improved. The improvement of this patient lies with the collective effort of each department that was involved with this patient. Thank you. And now I would like to invite Dr. Shweta, Professor, Department of IHBT, for the concluding note.
Thank you to all the presenters. A very good morning to respected Emeritus Chairperson Sir and other dignitaries and senior professors over here. So as we discussed about this case, this patient was admitted in Mahatma Gandhi Hospital for a multidisciplinary approach, as I can say for this. The patient was admitted on 31st of December 2025 and had a stay of approx 9 to 10 days, and 3 therapeutic plasma exchanges were done for this patient on the alternate days. And we have seen the drastic change in the investigations of the patient, and the patient was discharged on the 9th day in a very good condition, and there was no adverse reaction with the patient. In the last few years, the emphasis has been given to the therapeutic plasma exchange in different literatures, and the studies have also been published. Like in multiple journals, those are the PubMed and the journals from the international societies, they have showed the role of the therapeutic plasma exchange in different entities, like in hemolytic uremic syndrome, in optic neuritis, in GBS syndrome, in TMA associated pregnancies, and they have shown the very good results. But the role of the TP is more challenging when we initiate the TP on the right time. The early recognition of the signs and the early initiation of the TPE results in the promising results of the patient. This is one of the special report which has been published by the American Society of Haematology. They have also emphasized the role of TPE in the early initiation of the case. The meta-analysis have been done in 2018, even in 26 recently, on multiple centers, using study was done on more than 259 patients and 99 patients at different centers. They also showed the combined role of TP along with the immunosuppressants helped to save the life of the patient. So in this case, in pregnancy-associated TMA, the timely recognition and the early initiation of the TP can be life-saving, because TP is not just a treatment, it is a race against the time. So our department is very much privileged that we have done more than 800 TP procedures in last few years in different entities like optic neuritis, GB syndrome, post-liver transplant, ACLF, and the results were very compromising at our center. So from the behalf of the Department of IHBT, I thank each and everyone sitting over here, and I request all the clinicians that please consider the therapeutic plasma exchange at the priority so that we can save the life of the patient. Many a times what happens, getting a compatible blood for a patient is not that easy. Getting a compatible blood is as much as critical getting a compatible organ for the patient. Just like in these cases, TP has proven to be life-saving for the patient. So I thank the management for providing us the opportunity. So we are there to help the patients and to serve the apheresis services 24/7 our institute. So I request that the TP is the early initiation which helps to give the better outcome of the patient. It can be life-saving therapy, especially when guided by the appropriate indications, early intervention, and the multidisciplinary approach. In this case, the multidisciplinary approach by the different departments helped us to save the life of the patient. Thank you so much.